So we are welcoming Scott Langenecker. Did I pronounce that right? Langenecker?
You got it.
Thank you. He is a clinical neuropsychologist and associate professor of psychiatry and psychology at University of Illinois in Chicago. He's a native of rural Wisconsin, completed his graduate work at the University of Wisconsin in Madison, graduate work at Marquette University in clinical psychology, and then internship Long Island Jewish Medical Center. He did his postdoctoral fellowship in clinical neuropsychology at the University of Michigan. He was a faculty member, University of Michigan, from 2003 to 2012, and is now Director of Cognitive Neuroscience at the University of Illinois in Chicago. Scott's research and clinical work focus on the lifespan approach to mood and anxiety disorders, with particular focus on lifespan transitions, for example, from adolescence to adulthood. He's developing and adapting biological and cognitive tools to understand ways to identify and treat individuals with a past history of mood disorders, to reduce recurrence, decrease episode length and severity, and to improve functional and quality of life. He's a longtime educator and advocate in suicide prevention. Scott's educational commitments encompass predoctoral and postdoctoral trainees, instruction of various coursework, and community outreach efforts. On a more personal note, I learned that Scott has a great sense of humor, and he likes to cook, especially lately he's been smoking meats, so we're very much enjoying going to Chicago next time. And I'm very excited that Scott has agreed to present at our grand rounds, so please welcome him for his talk entitled The Neuroscience of Prediction in Depression, Subtypes, Treatment Response, Course, and Disease Burden. Thank you.
Thank you. Good morning. Thank you for your invitation, Dr. Esterlis, and thank you all for coming today. It's a great privilege to be here, and hopefully I can inspire or at least educate a little bit today. I'm going to tell you a little bit of a non-traditional story here because I'm one of the few academics who starts to talk by saying I've been doing it wrong. I've been doing it wrong for probably over a decade, and hopefully it'll become clear that I'm trying to get to the point where I do it right. And what do I mean by that? I've been trying to study traits that are risk factors for depression my entire career, and I've been studying people for most of that time in the active phase of illness. And that's sort of like saying that you want to study the risk for fever when people have a fever rather than actually studying the risk for fever in people who don't have a fever. And I hope to convince you of why that subtle distinction is incredibly important today, because it actually helps a lot with precision and measurement. I also start by thanking people because I get to present the work of better people who spend more time doing smarter and more elegant things than myself. The work that I'm presenting today is, so where's Natania's name? Natania Crane has done some of this work. Katie Bessett, where's Katie? She's somewhere in here. Way over on the right, there she is. Has done some of this work. Rachel Jacobs has done some of this work. And who else am I missing? And also some work by Katie Burkhouse. So those are the people who should get all the credit. I do want to thank the external, most of the data I'm presenting today is a Brains R01 award. My external committee was Wayne Drebitz, Mary Phillips, and Danny Pine, and also Melvin McGinnis, but he counts both in the internal and external world. All right, sources of support, so the Brains R01 that I was telling you about, also a little bit of data from an RDOC R01, a little bit of data from K23 and NARSAD, and then of course my lovely daughters are also a source of support. And conflicts, so that's my family. They're great conflict, they distract me from my work, and I love the fact that they distract me from my work. They keep me balanced. And then the official conflict slide. So I'm the board president for the Illinois chapter American Foundation for Suicide Prevention. So if I start talking about suicide, that's just me sliding into the wrong talk. Just slap me and I'll come back to this talk. I've done some contract work in the past for other groups. I do a lot of test development work. I like to say that I improve tests. I don't know if that's really true, but I like to say it. And most of the time I provide free help. So if you like what I'm talking about, I'd be happy to give you the tests, happy to adapt them, happy to help you to analyze them. And I guess there's witnesses, so I guess I did say that. Some of the treatment trials we're talking about today, the medication was provided, one study was provided by Lilly. I don't think I'm talking about that one. Another study, the medication was provided by Forest, which is not Forest anymore. But they had no impact on the way we analyzed the data or even the experimental design. And we didn't tell them what we were going to do other than to say we wanted to see if we could predict treatment response. So that's that. All right, let's get to the actual objectives. So one of the things I hope to convince you of today is that there's this thing called intermediate phenotypes. Some people call them endophenotypes. We've been playing with this concept for about 40 years now, and most of this is stuff that other people have come up with. I'm just rejittering it into a different point of view. But what I do want to convince you is that when we talk about treatment targets, those might actually be the same thing as intermediate phenotypes, but actually might be something entirely different. We're going to talk about the life course brain illnesses. I'm going to speak primarily about depression, and I hope to convince you of the importance of actually understanding the life position of an individual, both from an environmental perspective, from a developmental perspective, or from an aging perspective, and understanding the forces that are interacting with the disease that we think of as depression to cause dysfunction. We're going to talk about key domains of inquiry, that's the RDOC hint, illustrate the important role of disease features and symptoms, and then talk about critical points for assessment and prediction. And what I mean by that is are there places in time where a clinician would say to you, it'd be really helpful if I had a tool which would help me to know, for example, after somebody's had a first episode of depression and now they're well, do I continue with the treatment that we've been working on? Do we start a different treatment to try and prevent the next episode? Who's going to have another episode in the near future? Who might not have an episode at all? Can we define risk in a way to do precision medicine? And then we're going to talk about predictors of treatment course and naturalistic course in depression. All right. So this is stuff that you all know already. Depression is a chronic, recurrent, lifetime illness. 80% of the people who have first episode are going to have another episode at some point during their lifetime. We also have come to appreciate that it is not a static illness, it's an evolving illness. The analogy that I like to use for people is that it's kind of like relapsing, remitting MS. And I would put to you that we've done a lot of studies of intermediate phenotypes and treatment targets, but they've been a lot of cross-sectional designs and a lot of acute pre-post treatment designs, and I'm every bit as guilty as other folks in that. So we've moved to this focus on naturalistic disease designs because we want to actually ask questions that can be applied readily into clinical contexts. All right, so most of you probably already know or have heard of the concept of an endophenotype or intermediate phenotype. I want to emphasize that these things are heritable, that they're likely present before the illness. In fact, that's one of the key criteria. They're present outside of an acute episode. They're present in family members, which is the genetic link. And then there's this sticky one, this idea that they're independent of symptoms. I would put to you that they're actually potentially affected by symptoms. And one of the classic examples we'll talk about in just a little bit is neuroticism. And the other more newer concept is the idea of a treatment target. So is there a brain or a brain region, a brain circuit, a neurotransmitter, a cognitive skill, a emotion regulation skill, whatever you call it, that is a target for intervention? And that need not be the same thing as the thing that might be an increasing risk for the illness. In fact, we're increasingly coming to understand that we might be facilitating compensation or adaptation when we provide good treatment, rather than necessarily fixing some biological problem that led to the illness itself. And one of the things that's really tricky about this is that then you have to get into this business of proving that it changes as a result of, or otherwise is influenced by, or predates significant changes in the state of the illness. Basically, there has to be some temporal coherence between the treatment target and the resolution of symptoms. And the tricky thing about that, let me just give you an example. If I have a stroke standing up here today, and I hope I don't, the symptoms that I'm going to have are actually going to be immediate. and those are going to resolve over the course of a year, and they may not completely resolve. The actual resolution of the brain problem may actually not be at the same pace as the resolution of my symptoms. And that's why we get things like TIAs, which are incredibly difficult to measure. All right, so the other thing is that some of these intermediate phenotypes are also treatment targets. One example is neuroticism. So neuroticism is elevated during an episode, but it's also elevated after the episode, just not to the same extent. And it does decrease with symptom alleviation, and it is heritable. One of the things I hope to convince you of is that intermediate phenotypes or endophenotypes could potentially be masked during the active phase of the illness. And I'll show you a little bit of data that hopefully gets you at least questioning the value of setting people in the active state. So I'm going to skip over that and show you some data and hopefully convince you. So this is a paper we published in 2007. This is the sustained attention component of the go-no-go task. The control group sits here, and 5 different clinical subgroups all demonstrate sustained attention problems. So now we've come to refer to that as a non-specific global marker of illness. But when we talk about impulse control, though, things get a little bit more tricky. So folks who have an anxiety disorder are actually a little bit better at cognitive inhibition or inhibitory control, and you could think about reasons for why that might be. Folks who have depression, though, are actually not different from healthy controls in their inhibitory control capacity. However, if we study them during the remitted state, we actually do see a significant difference in inhibitory control. This is a second sample where we don't see a difference, and you could say, well, that's because your controls weren't as good performers. It actually looks as though you have similar levels of performance in active and remitted state here. But this is a much larger sample, and I tend to believe that one. The other thing to note is that this one actually was collected in our clinics at the University of Michigan, so it's representative of people who walk into a tertiary care facility for care. The idea that there might be shared cognitive deficits. So we published a paper a couple years back. We did a psychometric approach where we actually looked at what is the percentage of people who fall below certain Z-scores relative to the control group. So these black bars are the percentage of people with bipolar disorder who have impaired response time. But that's in the 0 to 5% range based upon the control sample. This slim gray bar is 6 to 9%, and this lighter gray bar is actually 10 to 16%. And what you can see is that actually about twice as many people in the bipolar disorder group have impairment relative to the control sample. A fairly similar number in major depressive disorder. When we look at accuracy in, this was in sustained attention, you can actually see that the problem is more pervasive in bipolar disorder than in major depressive disorder. Keep in mind this is attempting to, but ultimately failing to control for course of illness and treatment effects. And just wanted to give a shout out to the BSNP folks here. This is a recent study by Sheffield et al. Showing that global efficiency in the singular opercular network is actually something that is uniformly impaired across different subtypes of bipolar disorder and schizophrenia. So the idea that we can have shared cognitive deficits in many of our psychiatric illnesses is no longer a taboo subject. And it actually helps us to look at what is specific and what is shared. All right, so these are the reasons why I study remitted individuals. 100% of the people have expressed the disease, so that's pretty good. When they're in the remitted state, it's much easier for them to actually comply with many of the tricky things that we ask them to do inside and outside of the scanner. We give them really complex instructions for tricky tasks, and actually uniformly they try harder than our healthy controls who just want the $30 and leave me alone, thank you very much. There is a lot tighter variance in the measurement. I have a lot more belief in the sensitivity of it. It also helps us look at, with greater clarity, the hereditary patterns and links. Of course, obviously, we're diminishing the effects of symptoms, and none of the folks are currently undergoing treatment, which is a significant confound. The downside to this is that there are a substantial portion of people who have illness who don't get to the point of remission where we'd actually want to study them. So there are a certain subset of chronically ill patients who get to a Hamilton of 14, and that's as good as they're going to get, and they're not eligible for our studies. All right, so let me give you a little bit of a peek into why I'm really focusing and honing in on older adolescents right now. I spent the good part early part of my career making fun of people who studied this group of individuals, because I said there's so many things that are changing in late adolescence. You're changing your educational setting, you're changing your physical setting, you might be changing your occupational setting, you might be starting to experiment with drugs for the first time, you might be experimenting with sleep dysregulation for the first time. Why in the world would you want to study people in this phase of illness? Wait until they're more stable in their late 20s and early 30s. The reality is there's a developmental reality or a disease reality, that as you have more episodes of the illness, you're losing your capacity to be more specific about what it is that you're measuring. Are you measuring the risk factors for the illness? Are you measuring the effects of the illness itself? Are you measuring the effects of chronicity? You start to lose that level of specificity if you move into this safer and more stable part of the illness there. And there's a great draw to doing at-risk studies. But one of the problems with at-risk studies is most of the people that you study who are at risk actually don't go on to develop the illness. The other very pragmatic problem with studying at-risk samples is in the 5-year NIH extramural funding cycle, that's not long enough to actually follow people long enough to see the expression of illness. So you get a whole bunch of people in your non-ill at-risk group who at some point in time are going to develop the illness. They just haven't done it yet. So that's a weak quasi-experimental design. It's the reality of what we do. And so I started focusing on this period of early disease where people have had maybe one, maybe two. Sometimes people who have rapid cycling illness will have multiple episodes, but really early in the illness. The other thing is there's a neurobiological reality that most of our neural systems, I say that sometime in your mid-20s, you're at your peak neural efficiency, and the next day you're starting to decline. That's just the biological reality. It's not quite that stark. You get about 12 years where things are pretty stable. But the reality is that if you're looking at multiple episodes of illness, then you get into what we refer to as burden, where are you measuring the illness, are you measuring the symptoms, or are you measuring the chronic burden of the illness itself? So we've just sort of been honing in on this particular window. From a clinical perspective, it's also pretty useful too, because that's when kids leave the home, and it's really would be helpful to parents if we actually had some idea of how we could predict who's going to go on to develop illness or not develop illness. All right, so let me introduce this complicated model to you, and I didn't want this to be a complicated model. I wanted this to be a simple model, but I think this is the reality of major depressive disorder as we know it. So this is based upon an original model that Mary Phillips and Danny Pine and Wayne Drevitz came up with a couple years back, and I think Scott Rush was involved in this paper as well. So there's a stimulus, whether it's internal, external, that's presented to the individual. There's some assessment of salience or valence that's made, positive or negative, and then there may be some regulatory process that comes in later in the scheme of things. We know from a ton of research that there's this bias towards the negative in individuals who have major depressive disorder. There's actually a bias away from the positive. And as you develop illness, you develop a set of behaviors that are related to those appraisal capacities. So if you're never seeing the positive in life, then you're not developing a lot of positive skills. If you're seeing a lot of negative things, you're going to develop a lot of negative or avoidant skills. Likewise, we think that there's a diminished capacity for regulation and problem solving in major depressive disorder. So why this complicated diagram? Well, it turns out that not everybody has to have a regulation problem. Not everybody has to have a negative appraisal problem. Not everybody has to have a positive appraisal problem. Some variation of this can be present in every individual with depression. What we've sort of gotten stuck on, or had been stuck on for a long time is that every single person with depression had to have every representation of the biology of the illness. But that's kind of silly, right? Because we're talking about 5 of 9 symptoms. Not everybody has the same 5 of 9. So there's no plausible reason why we should expect every depressed person to have the same biology if they don't even have the same symptom presentation. One little additional note here is that there's actually a well-replicated bias towards the positive in people who don't have a history of illness. It's a long-winded way of saying is that there's many roads to Rome. And we've been sort of concentrating on, oh, I'm the cognitive control guy. I'm going to focus on this road to Rome, and all you people focusing on these other roads are wrong. Well, the reality is that we're probably all right for some patients. And if we're all right for some patients, we have to take this multimodal approach. And this is where I move into sort of this very brief illustration of what I think RDOC can do for us. I think of RDOC as a complementary tool to DSM, so I sit on the fence, and I think that's where any objective scientist should sit. And we use the tools that are best to the research questions that we have at our disposal. So we have cognitive domains, we have positive valence domains, we have negative valence domains, social domains, and arousal and regulatory domains. Within a given subdomain, you might be able to break it down even further and further into different levels of granularity. So we talk about cognitive control. We might be able to break that down into goal selection, updating, representing and maintaining. What I'm interested in, selection, inhibition, and suppression, and then variations of inhibition and suppression. And we don't actually know which level of granularity is actually most important, or if any of them are even important. And that's kind of the whole point of these RDOC experiments. A lot of people don't like them because they're data-driven, exploratory types of experiments, and we sort of get taught over and over again, what's your hypothesis? And the hypothesis for RDOC is we've gotten pretty far in understanding and treating our psychiatric illnesses, but we're kind of stuck, and we need to get unstuck, and maybe this will help us get unstuck. So that's my way of viewing it. The thing that I think is super cool about RDOC is we can imagine that every person, once we get to the point, and we'll probably never get to this point, but this is a nice illustration, so don't pick on it yet. Each subdomain would have a potential T-score, and this would be a combination of biological, performance, and self-report instruments that sort of aggregate into a factor or a domain. And each person would sit at a different place on that dimension. And your place on that dimension, in aggregate, as a pattern, would illustrate not necessarily your disease, but perhaps several different avenues for treatment. So for example, this person's a little bit high in their positive valence, a little bit low in their negative valence, a little bit low in their cognitive control. And you can imagine probably several different disorders that might fit this particular phenotype. I drew this up with hypomania in mind, but you could think of other illustrations. Back to my distractors. This is actually probably not there anymore. This is Ilyonke, and just a bit of a note of thanks to the folks who are helping out for all of the hurricanes that we've experienced recently. So this is the primary study I'm going to be talking about today. It's a longitudinal design, dense phenotypic measurement at baseline, including self-report. We actually interview the parents, because we have this thing where people come in just to get money to do research studies. And so if we actually ask them, can we talk to your parents? And they say no, then say, can you talk to a therapist? And they say no, we say, well, thank you very much. We don't want you to be in our study, because we can't be confident that they're actually being truthful with us. Neuropsych testing, fMRI. We jumped on the reliability bandwagon before it was a reliability bandwagon, so we repeat all the measurements between 4 and 12 weeks later. And then we actually do a one-year follow-up. This is just the consort diagram to show you, screened a bunch of people, consented a bunch, and by the time we get down to the functional MRI, we have 61 people with a history of depression, 48 who have a history of no mental illness in themselves or their first 3 family members. A bunch of them stuck around with us, good retention. And then we actually had 21 people who had recurrence of illness, 35 who did not have recurrence of illness, 42 healthy controls, and then 4 healthy controls who went on to develop a first onset of illness. A little bit about the inclusion-exclusion criteria. We wanted people early in the course of illness. The mode is actually one episode. About 50% we were targeting for a comorbid anxiety disorder. We got to, I think, 42%. About 50% with a positive family history. We're pretty close to that. No current medications. We do have some people who had continuation psychotherapy, but we wanted people who were sort of, in the maintenance phase there. Age 17 to 23. And then we matched people on all the relevant demographic features, no personal history, and a negative family history. So this is just the demographics. The beauty of having a tight age range is all the demographics line up. They're equal in age, they're equal in education, they're equal in IQ. You can see that even though the folks are remitted, their GAF scores are actually a little bit low. You can also see that this might be a group that's actually pretty high functioning. So on average, they've been well for 2.8 years. On average, they have two prior episodes. Their Hamilton scores are quite low. So this is the task that I've been working with for my entire career, and I can't find a good reason to get rid of it because it keeps on illustrating important things in illness. So this GO part of the task is sort of a standard continuous performance task amongst a serial representation of rapidly presented letters. You look for X's, Y's, and Z's and press the button when you see them. Don't press the button for anything else. And then we make it more challenging. We say, well, I want you to remember the last target that you responded to. That last target is now a no-go item. So once I respond to Y, that Y becomes a no-go item, and the X and Z are the go items. Once I respond to this X, then the Y shuffles back into the go set, and the X goes into the no-go set. So you're constantly updating your go and no-go sets. This is just an illustration of the data. So the healthy controls, this isn't significant, but it's in the expected direction. Healthy controls are a little bit better than the remitted depressed folks. This is the inhibitory control measurement. So at baseline, they're different. They remain different at the repeat assessment. And now let me show you what we can do with this particular task. So this is a paper that Natanya Crane published early last year. I can't remember now. So there was some evidence that executive function can improve with treatment in depression. There's also some evidence that executive function is predictive of treatment response, but it's relatively understudied. And what I've done is I've sort of made a bar graph. So the y-axis here is the number. Actually, let's move on to the next graph. It's easier to see. So the y-axis is the number of subjects that are enrolled in the study. The color coding is actually based upon the cognitive or affective domain. You can see a lot of purple in there. Purple is emotion processing. In depression, you'd expect a lot of studies of emotion processing. Red, which is what I'm interested in, and my road to Rome, is relatively understudied. And there's a few extra things in here. There's a verbal expression task. There's a few reward tasks. There's a resting state task. But the important thing to note here is that the mode or the median for a number of subjects in these studies is about 20. And those of you who know statistics know that that's woefully insufficient. And it's insufficient for reasons that are a little bit tricky. So let me try and explain. Because we go through so many steps to actually screen people in and out of our studies, comorbidities, BMI, reading capability, medication status, we get people who are actually functioning sort of at the higher end of functioning. And by virtue of that, those of you who know the YAVAS acronym know that those folks are more likely to respond to treatment. So we're really good at identifying people who respond to our traditional treatments, and about 70% of people who go into these types of trials will actually respond to the treatment. That's further confounded by the fact that some of them are actually responding to the placebo of treatment too, right? So we may be predicting movement to wellness more so than treatment response. But with that in mind, I'll try and convince you that this is important. So we had 29 people who completed the more complex part of the study, 37 people who underwent fMRI prior to receiving treatment with either escitalopram or duloxetine for 7 to 12 weeks. 29 of those folks went into independent component analysis. Those of you who know independent component analysis know how sexy and cool it is It's actually really complicated, but the basic premise behind ICA is that if you're in a crowded room or a bar and you're trying to listen to the conversation next to you rather than the conversation that you're having, you actually have to dissociate out those two different signals, and your brain naturally does ICA. You can actually do it computationally with a computer. You can also do it spatially, and that's what we did in this particular experiment. So what we did, let me just tell you a little bit more about this. So one of the important things in any treatment study is to make sure that you don't have any unwanted biases in those folks who complete the treatment relative to those people who start. And I can assure you that there are no such biases. All of these things that we might care about are actually relatively equivalent, and statistically are equivalent. So when we do independent component analysis, I want you to focus first on the yellow regions. So this is a right lateralized cognitive control component. This is the one where, if I was sitting at the table in Vegas, I would put all my money on this particular component, and I would have lost it all. That's why we do science. So all of these different color combinations illustrate the different components, the ones that were relevant for treatment prediction. Actually, let me back up one step. So one of the really cool things about ICA is you can actually link or delink ICA from the actual events that are occurring during the task. So we have people who are correctly responding to the go targets. Everybody does that. We have people who are correctly not responding to the no-go targets. Everybody does that. And we have most of the people who are incorrectly responding to the no-go events. There's some people who just perform too well, and that's why we go on from 36 to 29, is we have 9 people who actually didn't have enough errors to model correctly in the ICA. Then we can actually look at these components as they relate in a temporal fashion to the cognitive tasks that they're actually engaging in. So the go, the no-go, and the failed no-go. So these are 2 components. Actually, let me back up. Let me alert you to the colors. So the blue component, which is sort of a broad swath of dorsomedial prefrontal cortex and rostral frontal cortex, and the red component, which is basically dorsal medial prefrontal cortex. There's a little bit of lateral prefrontal in there as well. Those 2 components were significant predictors of treatment response. And because we got to go through multiple rounds of resubmission and revision, the paper got substantially better. And I mean that sincerely. It went from something that was pretty cool and pretty good to something I'm really proud of. And I thank whoever reviewed the papers in the multiple iterations for helping us get there. So they said, well, you haven't replicated this finding. It could all just be noise. And so what we did is we did a 5-fold cross-validation of the ICA. We actually brought in the 7, there were 9 people who had the scan but dropped out. We brought them into the ICA, and we actually specifically sorted people into 5 different folds based upon the proportion of responders, non-responders, and dropouts. And you can actually see here really nicely that the red, which is near perfect concordance, overlaps across all of the 5 folds substantially with the original. This is the component 24. In component 25, it fits a little bit less well, but it fits a little bit less well in a place where you wouldn't want it to fit terribly well, which is in the lateral ventricles. So the green here is a little bit less well fit, and there's some of the folds that don't do so well with that. So these are just some scatter plots of the prediction. The reviewers really were excited about differentiation between who responds to escitalopram and duloxetine. Remember, there's 29 people, and so we said, well, we don't want to do that, and they said, no, you have to do that. So there's something in the paper that looks at differentiation of treatment response. Please ignore that. It's probably not going to replicate. When you put that into a classification algorithm, 90% accuracy in classification. When you put it into a random forest classification with cross-validation, it drops down a little bit, but it's still pretty darn good. For those of you who want to know whether this is something usable, it's not usable. If you want something to be usable, you really kind of want to get up above 95% to be usable at the level of an individual patient. So it's sneaking up there, but it's not quite there. So So let me show you another study. This is the data, the follow-up data from the study that I reported to you earlier. Let me just check my time here. I got to 11:15, and then we have questions? You can go. Yeah. Yeah, I'm not going to go that far. All right, I'll stop at 11:15. All right, so this is that longitudinal naturalistic study that I told you about. So we started out with 75 people who had multiple measurements of the PHQ, and this is the word to the wise. The PHQ is 9 items, and in fact, it's only 8 items because we had to drop out the suicide item because the IRB didn't want us to ask people about suicide if we couldn't respond immediately. And so we dropped it out. Of over 700 people that we assessed with our cognitive task, only 75 had repeat assessment with the PHQ. This is in a really high-functioning, great university. This is the problem that, I'm going to step on my soapbox just for 1 second. This is the problem we have in psychiatry, is we don't trust our tools. We have to trust our tools, we have to use our tools, and we have to actually help them to help us to monitor treatment. So whatever scale you want to use to measure the symptoms that your patient has, make sure that they use it, because it actually helps you to understand how well they're doing. You're actually asking all the questions about the symptoms anyway, so it's not that hard to do some of the scale measurement. Okay, off the soapbox. So 75 people who had multiple PHQ measurements, they, on the majority were prescribed a change in medication or a change or a start of therapy. Note that the majority of those, 20, I think that's 29, I can never read it, 29 never completed an adequate dose of psychotherapy. Of the 19 who got an adequate dose of psychotherapy and medication, you can see that they're actually distributed a number of different ways. Very few people who walk into a tertiary care clinic are going to get psychotherapy only just because of the nature of the illness. So if we try and use our cognitive control task to predict who is going to have resolution of symptoms with treatment, the marker that is significant is processing speed with interference. So that is the response time during the no-go task. When people are asked to respond to the go items and not respond to the no-go items, that a little bit too much hesitation in identifying the go item in that complex task indicates the people who are going to respond less well to our standard treatments. And you can really see here, this is just the data broken down a little bit differently, that it's the people who are in this slower processing speed tertile that are driving this diminished reduction in the PHQ symptoms. People with moderate or fast processing speed with interference resolution actually do well. The other thing I want you to alert you to, these are all Z-scores here. The full responders have the closest processing speed to the healthy control group, significantly different than the people who don't respond. But look at the people who are lost to follow-up. So the people who are actually not filling out those PHQs or not coming back actually are having significantly more cognitive difficulty than the people who don't. And that might be an duh moment or an aha moment, but this is something we can actually use to actually help us to engage people so that they actually stay in treatment better. And then these two groups here are people who are partial responders or who respond and then relapse, and you can see they actually have the most difficulty. All right. For those of you who know, this is the coqui frog. They make beautiful, beautiful sounds in Puerto Rico. They're probably not very happy right now. So we're going to transition to my new love, resting state connectivity. This is an original paper by Bharat Biswal in 1995. And the premise of this was basically that when you do a motor task in the, this would be left hand, you actually get activation in the motor cortex for the right hand and vice versa. And why would that be? And that has led to a number of pretty significant breakthroughs in understanding that we have these coherent intrinsic networks that may move together. So there's the posterior cingulate cortex and the medial prefrontal cortex that are yellow and red and kind of move together. And then we have this inferior parietal sulcus, which actually kind of moves kind of on its own, but maybe even the opposite direction. And we can capitalize on those temporal signals to actually illustrate different coherence in different networks. And this was the study by junior faculty Rachel Jacobs working with me that sort of convinced me that resting state fMRI has a lot to offer. For one thing, it can be done in many medical centers. It doesn't require a lot of the technical sophistication that we have for task-based fMRI. And it's actually relatively short. So this is a comparison of people with active depression to people with remitted depression to people who are healthy controls. I want to alert you first to the fact that half of our active depression sample we had to throw out because they had too much movement. A much lower percentage in our remitted MDD sample. So you're getting my bias in full force here about why studying remitted people might be better. We get a little bit of movement in the healthy controls. We use the left posterior cingulate cortex as a seed and the left amygdala as a seed. You can see that there is actually a node in the right superior frontal gyrus sort of blending into the middle frontal gyrus that is actually hyperactive both in the remitted state and the active state. That's kind of exciting. Then you can see another one in the precuneus that actually is really only elevated in the active state. So you can start to sort of think about this dissociation between what is an expression of the disease in the active state and what is an expression of the disease in the dormant state. And then this is just some other illustrations. So this is the left subdennial anterior cingulate. You can actually see that the remitted group is the group that shows hyperconnectivity, and the active group doesn't show any difference whatsoever. Same thing here in the left subdennial anterior cingulate, connectivity to the left hippocampus. And this was the one that really kind of said to me, okay, I guess I can't say that resting state functional MRI has nothing to offer. So we broke people down into whether or not they had a single episode of MDD or whether they had multiple episodes of MDD, and that was where the money shot comes in. So we'll start with the money shot. This is connectivity from the amygdala to a broad swath of the ventral striatum and the orbital frontal cortex, medial prefrontal cortex. In the single episode people, it's actually elevated. In the multiple episode people, it's actually hypo-connected. And that is irrespective of whether or not you have active symptoms or not. So there's this idea that the disease, as it progresses, is changing the way the brain is connected. Now, those of you who know this stuff well can say, well, you know, some of those single episode people aren't going to have any more episodes, so maybe it's just some sort of sampling bias, and you're just capitalizing on the fact that the people who have a single episode are just different, categorically different. And that's a true statement. And then when you look at the posterior cingulate connectivity to these two regions in the middle frontal gyrus and inferior frontal gyrus, you see that same sort of separation where single episode looks different. As an aside, this is the type of stuff that's driven people mad, or nearly mad, who study MCI and transition to Alzheimer's. The same sort of patterns of hyperconnectivity, then transitioning to hypoconnectivity as you move from the acute to the chronic phase of an illness. Maybe that says something more about the reorganization of the brain with illness that's not specific to depression. I don't know. All right, back to our slides. So just illustrating that number of episodes matters more than perhaps we thought. All right, so let's move on to one more story before we close. So we asked the question, can we use functional MRI and neuropsychological candidate intermediate phenotypes to predict of those people who are currently well, walking through the door with a Hamilton of 2 or a Hamilton of 4, are you likely to have a recurrence of illness in the next year or not? And because we have repeat assessment, are those predictors reliable? And then there's distinctions on reproducibility and stability that I don't want to get into today, but just put those there for folks who know the distinction. All right, so on average, these remitted depressed people were well for 2.5 years. So the likelihood is that they're probably not going to have another episode. Even so, we get a relapse rate of 36%. We were hoping for 50% because 50% is a perfect division of the groups, but we'll take what we can get. And like I said before, we had 4 of our healthy controls who converted to an illness for the first time. That translates to an odds ratio of 4.9, which is pretty decent. So what are the predictors we're going to talk about today? We're going to talk about go-no-go performance, go-no-go activation, and we're also going to be talking about connectivity in networks that are important for those particular things. All right, so busy slide here. This is errors, so when people respond to the no-go stimulus when they're not supposed to. Healthy controls network, here in green, lovely illustration of the cognitive control network with a little bit of salience network thrown in. In the remitted folks, you can actually see a little bit less activation, but same network shows up. And in the folks who are remitted and go on to develop another episode, you can actually see, at least I can see, the stats don't bear this out, but it seems like there's something really going on the anterior insula here that makes them a little bit different. But that's probably just me. But this is where things get really interesting. So the people who go on to develop another episode in the subsequent year have bilateral deactivation in the dorsolateral prefrontal cortex at the point in time where they're supposed to be inhibiting a prepotent response. And as I was telling Mike and Godfrey a little bit earlier, if I was drunk with crayons drawing where I wanted to put the circles, this is where I would have put the circles. Maybe a little bit bigger on the right is where I would have gone, but it's pretty good. When you actually extract the data and plot it, it's visually breathtaking, at least to me. I'm biased, I know. So what happens when people are actually correctly inhibiting the no-go stimulus? Well, here you can see it's actually a much more right lateralized network. So remember that yellow independent component that I was referring to before. This is a pretty good illustration of that yellow right lateralized cognitive control network. And there's not, the only thing I want to point on here is there's a little bit more bilaterality in the depressed group, perhaps in the prefrontal cortex and also in the insula. There are some differences. They're not quite as breathtaking when you put the scatter plots up there, but look what shows up. So this is the second time that the subgenual cingulate has come up in a depressed sample. In our original paper in 2007, it was predictive of treatment response in a sample. Here it's actually predictive of those folks who are going to go on to have recurrence of illness. You can say that it's, I'm trying to remember which bar is this. It's the middle bar. You could say that that's probably hyperactivation, but it looks pretty variable to me. So I don't know that I'd put much money in that. We also focused on the amygdala, and you get sort of the same pattern. So a fair interpretation is a failure to deactivate, maybe. I'm not going to put a lot of money on that one. So then you have these sort of two nodes that are really sort of relevant, right? You've got dorsolateral prefrontal cortex, and you've got subgenual cingulate. So let's actually go and probe those same regions, but now using resting state functional MRI. When we drop a seed in the right lateral prefrontal cortex and look at connectivity, you get this broad cognitive control network. Looks pretty similar across the groups. There's a difference in the right dorsolateral prefrontal cortex. So the resilient has more connectivity there than the recurrent group, I think, if I'm reading this right. Yep. And then look what happens. The subgenual cingulate actually is elevated in connectivity in the group that's going to go on to have recurrence of illness in the next year. When you drop the seed into the subgenual cingulate, you see this nice salience and emotional network come out in the healthy controls. Similar patterns in the depressed groups, but there are some interesting differences there. But now look at all the regions that are elevated in connectivity in the group that's going to go on to develop another episode in the subsequent year. And if you sort of, again, pull out your crayons and drew out the cognitive control network, you do a pretty good job of covering it. You've got dorsolateral prefrontal cortex, inferior parietal lobule. It's more right lateralized than not. You got this huge area here in the inferior temporal gyrus. And the first time I saw that, I said, oh, great. I'm going to have to try and figure out what that particular region is important for. In the intrinsic network maps, it's actually a part of the cognitive control network. I still couldn't tell you why it's important, because that's actually like a symbol detection region. But anyway, symbol detection task. But this is resting state. All right, so we have all of these. We put them into a predictive omnibus model. We do the same sorts of things with cross-validation and support vector machines as before. We get 89% accuracy using the baseline data to predict recurrence of illness. Again, scarily close to something useful, but not quite there yet. And then importantly, with the retest data, the accuracy drops down a substantial amount, but it's still a good number. And then you put it through all of the cross-validation steps. So use the random forest with 10 trees, leaving out cross-validation, still 85%. Then you put it into receiver operating characteristic, 89%. And these are different ways of illustrating the same effect, so the numbers, of course, are going to end up being relatively similar. And then you get to this complicated diagram. This is just an illustration of the relationships between all of the predictors. And the important thing to note here is that these resting state fMRI connectivity predictors are the most stable predictors. So, me, the task fMRI guy, is saying resting state fMRI is pretty darn good. All right, my daughter scaling at an iguana there in Puerto Rican Beach. All right, so one more final thing before I close. I've got 8 minutes, I'm doing good. So this is a paper that just came out recently by a postdoc, John Stange, who I forgot to thank at the beginning, but now I'm thanking him, looking at the cognitive control network. Again, you can see I'm perseverating on this cognitive control network. Sorry, I just do that. The way that we looked at this is we sort of took the really cool paper that Yeo and Buckner put together in 2011, and I think I've trying to set the record for a number of times I've read that paper. I understand about a third of it thus far. I'm getting there. But the really cool thing is they actually did a very transparent representation of their data analysis techniques. And we took 3 of the nodes that they had in their analysis, and we thought, if 3 bilateral nodes can't represent a network, then it's probably not a network. So we put dorsolateral prefrontal cortex, inferior parietal lobule, dorsal anterior cingulate as nodes. And as you can see, the dark, or the light orange rather, are an illustration of regions that have overlap in all 3 of those nodes. So I do believe that this is a good representation of that network. We look at the overlap between each of the given seeds and the total network, and you can see that the best seed is the inferior parietal lobule. DLPFC does pretty well. Dorsal anterior cingulate's a little bit trickier, and for those of you who know this work well, there's literally 4 different networks that converge in the dorsal anterior cingulate, and so where you put your seed is actually pretty tricky. Oh wait, the important thing. So, I forgot all about this. So you z-score the connectivity. This is the controls at baseline. These are the controls at follow-up. These are the depressed groups at baseline and follow-up. Significant difference. This is not a significant interaction. This is just being honest and representing our data. Maybe if we had another 10 people, it would be significant interaction. But the important thing is that the disease group is rock solid, stable. And I didn't mention it before, but that's actually highly reliable over time. All right. So back to our story about why does this matter. If you look at the relationship between rumination, which is a well-known marker of illness, you can actually see that this connectivity in the blue, that's the remitted depressed group, the people who have the lowest connectivity have the highest rumination. And it's exactly what you'd expect, right? People who have less braking capacity in their neural networks are more likely to sort of stick to this common cognitive or affective process that's upsetting them. And as you might also expect, those people who are better at inhibitory control have higher connectivity in this network as an aggregate. All right, so now just showing you those networks. I'll skip over that. Come back to the objectives. So hopefully I've gotten you to think a little bit about the difference between these intermediate concepts of intermediate phenotypes and treatment targets. Hopefully I've convinced you that studying depression between 18 and 55 in the active phase is probably not a good idea. And we talked about cognitive control. We talked a little bit about other domains, but mostly about cognitive control. Talk a lot about disease features. Didn't talk about age of onset today. Age of onset matters a lot too. I just don't have enough data to convince myself or you that that's relevant, but I believe that it is. But number of episodes and symptoms matter. And even the amount of time well matters. So I didn't show it today, but if you look at people who have been well for more than a year and compare them to people who have not been well for more than a year, again, this cognitive control network is significantly impacted in the people who are recently ill. And so the question we can ask but don't have the data for yet, does that mean that they have a different disease process, different disease course? Or is it a marker that cognitive systems are slow to recover once somebody's had a depressive episode? Interesting question, don't know the answer. And then hopefully I've illustrated to you that there are predictors of treatment course and naturalistic course in depression. And the sun will come out for depressed people sometime. Exactly. So thank you so much for your attention.